Welcome to episode 35 of the Pro PA podcast. I'm your host, Prof G, and today we're tackling a topic that can feel overwhelming but doesn't have to be: Pulmonary Function Test Interpretation, or PFTs for short. This episode will focus on my stepwise approach to interpreting PFTs, breaking the process down into manageable steps so you can confidently diagnose and assess pulmonary conditions. We'll also cover the basics of lung volumes, spirometry, and diffusing capacity, or DLCO, to set the stage for successful interpretation. By the end, you'll have an easy and systemic method you can apply on the PANCE and in clinical practice. Let's dive in. First, let's take a look at the kinder patho. What are PFTs? Well, it's not really patho, it's more just kind of background. What are PFTs? Well, pulmonary function testing is a group of tests that measures different aspects of lung function to help evaluate for respiratory diseases. And PFTs assess multiple things, including lung volumes, which are things like the total lung capacity or residual volume. They also measure airflow. This is what we like to term spirometry. We look at the forced expiratory volume in 1 second, or FEV1, the forced vital capacity, or FVC, and it also looks at gas exchange. And in this case, we refer to that as DLCO, which measures how well oxygen diffuses from alveoli into the bloodstream. So, why do we order PFTs? Well, they're used to evaluate unexplained dyspnea, cough, or wheezing. They're also used to help monitor disease progression in diseases like COPD, asthma, or interstitial lung disease. They also help us assess response to therapy. They help evaluate preoperative risk. And they help us screen for toxic effects of medication, for instance, amiodarone. All right, here's where we start the stepwise approach to PFT interpretation. So listen up, try to follow along, and if you have to, rewind and review again. PFT interpretation can seem complex, but following a stepwise algorithm makes it much simpler. Here are the key steps. Step 1. Examine the FEV1 to FVC ratio. This is going to be your first step to determine if there is an obstructive defect. A normal FEV1 to FVC should be greater than or equal to 70% or greater or equal to the lower limit of normal based on age, gender, height, and race. For the simplicity of this podcast, let's go with greater than or equal to 70%. If the FEV1 to FVC ratio is low, this indicates an obstructive process like COPD or asthma. So, this is the very crucial first step. Is the disease obstructive or normal, non obstructive? Step 2, we want to examine the TLC. So, the total lung capacity helps differentiate restrictive lung disease from normal or obstructive patterns. So for low TLC, low total lung capacity, less than 80%, this is going to suggest restriction. So a low TLC suggests restriction. So we'll see that in interstitial lung disease, obesity, or hypoventilation syndrome. A high TLC, greater than 120%, indicates hyperinflation, and this can be common in emphysema. All right, next step, step 3, review the DLCO. So the diffusing capacity for carbon monoxide, or DLCO, helps us evaluate gas exchange at the alveolar level. So a low DLCO is seen in interstitial lung disease like pulmonary fibrosis. It's also seen in emphysema or on pulmonary hypertension. A normal DLCO can be common in asthma or in obesity-related restrictive patterns, essentially anything outside of the lungs that's causing trouble with lung filling and gas exchange. All right, step 4, determine reversibility of obstruction. So if an obstruction is present, we're going to want to test the patient with a post-bronchodilator response. And this is going to be especially in those cases where we are thinking they could possibly have asthma versus COPD. So we want to see an increase in the FEV1 greater than or equal to 12% and 200 milliliters, which will suggest asthma. These are very important values. You need to commit them to memory. So again, you will see an increase in the FEV1 by greater than or equal to 12% and 200 milliliters, and this will suggest asthma after a post bronchodilator. If there is no significant change after post bronchodilator, then this might suggest COPD. All right, step 5, bronchoprovocation, and this is only if needed. So, for patients with suspected asthma, but they have normal spirometry, we want to consider bronchoprovocation testing like a methacholine challenge. And this is to see if they truly do have that reactive airway. So, with a bronchoprovocation test, if we see an FEV1 decrease by greater than 20%, this is a positive test for asthma, most likely. Step 6, grade the severity of the abnormality. We want to use the FEV1% predicted to grade severity. So, a mild would be an FEV1 between 70 and 80%. A moderate is an FEV1 between 50 and 69%. Severe will be FEV1 30 to 49%, and very severe will be FEV1 less than 30%. All right, step 7, establish a differential diagnosis. So, I think one thing that makes it really tough for students to understand is they see a set of numbers, PFTs, and they think that in the real world, it's the set of numbers that have to be interpreted. However, in the real world, we have a patient that has those numbers. So we know their clinical history, we know their symptoms, and it's easier to put those pieces together to figure out that diagnosis. But we have to establish a differential. So we're going to combine all the findings, the FEV1 to FVC ratio, the TLC, the DLCO, and reversibility, and we're going to use the clinical context to help establish a diagnosis. Step 8, and the last step, is going to be to compare to prior PFTs if they are available. So you always want to evaluate for changes in lung function over time to assess disease progression or response to treatment. All right, let's do an example case. Let's apply this stepwise approach and see where it takes us. So we have a 60-year-old man with a 40-pack-year smoking history who presents with dyspnea on exertion. His PFT results are, we'll talk about it in percentages. So this patient has an FEV1 with 25% predicted, an FVC of 41% predicted, an FEV1 to FVC ratio of 61%, a TLC of 150% predicted, and a DLCO of 98% predicted. So let's do this step-by-step interpretation. Step 1, we need to look at that FEV1 to FVC ratio. We should see that a 61% ratio is going to be less than 70%, which would indicate that this is an obstructive process. So now we are going down that part of the algorithm. Knowing that it's an obstructive process, our differential is going to narrow basically between COPD and asthma. Next, we want to look at the total lung capacity. Remember that a total lung capacity that is elevated can be consistent with hyperinflation. And in this case, the patient's 150% predicted is going to be elevated. So it is consistent with some hyperinflation. Next, we want to look at the DLCO. So the DLCO is going to look at that diffusing capacity. His is 98%. So this really helps us rule out a significant diffusion defect. So more than likely not emphysema on that obstructive side. Then we want to look at reversibility. So we have a post-bronchodilator FEV1 and it improved by only 6%. Is that enough to be a significant reversibility? No, it's not more than 12%. So this is more consistent with the COPD, more than likely more chronic bronchitis. And the diagnosis based on the FEV1, which is 25% predicted, would put us in the severe or very severe category of COPD with hyperinflation. All right, hopefully that wasn't too bad. Now let's look at the book med versus street med. So book med is going to focus on this stepwise interpretation and staging of disease. For your PANCE exam, I don't anticipate they will go deep into them. You are going to have to know those standards, less than 70% obstructive. You are going to have to understand what the different numbers mean and how to use them to interpret it, but they're not going to give you crazy numbers and calculations and things like that. You're going to have to look for the patterns like the reduced DLCO in emphysema versus normal DLCO in asthma. And that's really what you have to be able to do with the results that you're given on an exam. For street med, patient symptoms and history heavily influence the interpretation of PFTs. And a lot of times, PFT patterns don't always fit the textbook definitions. So we always want to consider that clinical picture. All right, some last clinical pearls before we move on to our knowledge check. Number one, obstruction is defined by a reduced FEV1 to FVC ratio, less than 70%. Always confirm reversibility to differentiate between asthma and COPD. Restriction, it's indicated by a low TLC, and the DLCO helps confirm interstitial lung disease versus other causes. So if we find that the FEV1 to FVC ratio is greater than 70%, it's either going to be normal or it's going to be a restrictive process. And that's why we go on to that TLC. If we see that the TLC is less than 80%, it is more than likely a restrictive process. Now, next, DLCO is reduced in diseases that impair alveolar capillary diffusion, such as pulmonary fibrosis or emphysema. So be sure to look at the DLCO as well. Always compare to prior PFTs to evaluate for progression or treatment efficacy. And number 5, practice interpreting PFTs with clinical cases. This is the best way to master them. All right, now it's time for our knowledge check. So we have a 50-year-old male who presents with dyspnea and productive cough. Spirometry reveals an FEV1 to FVC ratio of 65% and a post-bronchodilator FEV1 increase of 8%. TLC is 125% predicted. What is the most likely diagnosis? Is it A, asthma, B, chronic obstructive pulmonary disease, C, idiopathic pulmonary fibrosis, or D, sarcoidosis? I'll give you a few seconds. If you said B, chronic obstructive pulmonary disease, you are right. This is definitely COPD. The reduced FEV1 to FVC ratio indicates obstruction, but a lack of significant bronchodilator reversibility and the hyperinflation, or the elevated TLC, points to COPD. Question 2. 35-year-old woman presents with progressive dyspnea. PFT reveals an FEV1 to FVC ratio of 85%, a TLC of 70%, and a DLCO of 45%. What is the most likely diagnosis? Is it A, COPD, B, asthma, C, idiopathic pulmonary fibrosis, or D, pulmonary hypertension? I'll give you a few seconds. If you said C, idiopathic pulmonary fibrosis, you are correct. This is a restricted pattern. We see a normal FEV1 to FVC ratio and a low TLC. We also see a reduced DLCO, and this is consistent with pulmonary fibrosis. All right, well, I want to thank you for joining me on this episode. I hope it has helped you simplify PFT interpretation with my easy, stepwise approach. If you found this helpful, stay tuned for more episodes covering high-yield clinical topics. If you want a deeper dive into PFT interpretation with visuals, please check out my episode on PFTs on my YouTube channel, Professor G PAC, and consider subscribing. Don't forget to follow the podcast and turn on notifications so you never miss an update. And as always, this is the Pro PA Podcast, where future pros in medicine are made. I'll see you soon.